Good morning or good evening. This is Mark Arnold, Senior Vice President of Marketing with Zap Surgical. Welcome and thank you for joining us today for our 7th webinar of the Winter SRS webinar series. Held every Thursday between now and May 13, this new series does include 12 talks over 12 weeks. So if you haven't already, I encourage everyone to visit the srswebinars.com website to review not only the upcoming presentations, but also register to view recordings of prior webinars as well. And one final item of business before we get started. If you'd like to submit typewritten questions at any time during today's talk, you can do so by using the Q&A button found in the Zoom console. And time permitting, your questions will be addressed at the end of today's presentation. So without further delay, I'd like to introduce today's moderator, Dr. John Adler. Dr. Adler is the CEO and co-founder of Zap Surgical, inventor of the CyberKnife system, and professor emeritus of neurosurgery and radiation oncology at Stanford University. Dr. Adler.
Thank you, Mark, and good morning, good evening, wherever you are in the world right now. So I'm delighted to introduce today's speaker is Manjul Tripathi, who is one of the premier shining lights in radiosurgery out of India. He is an associate professor in the Department of Neurosurgery at the Postgraduate Institute of Medical Education and Research in Chandigarh of India. Of note, though, his focus is on functional neurosurgery, especially gamma knife radiosurgery and other forms of neuro-oncology and neurotrauma. He's widely works in the field of functional radiosurgery, looking at pain and movement disorders, and importantly, psychosurgery. And quite interestingly, and I just came to appreciate this, he has translated our good friend Antonio de Sal's book, Why Fly Over the Cuckoo's Nest? Psychosurgery in My Brain, Please. So he translated into Hindi for Indian readers, which I find a little cool factoid. So I'm delighted, Manjul, that you can speak to us this morning. Your topic this morning for the audience is going to be the current roles and limitations of radiosurgery and the management of glomus tumors, i.e. paragangliomas. So Manjul, take it away. Tell us why radiosurgery is always the right answer for paragangliomas. I mean, that's a prejudice of my own, but I'd like to hear what you have to say. Thank you. Welcome.
Thank you, John. Thank you for this nice introduction. I believe my screen is visible to all now. So I'm sincerely thankful.
It looks great.
I'm sincerely thankful for giving me this wonderful opportunity to discuss the current role and limitations of radiosurgery in the management of paragangliomas. And I'm a microneurosurgeon and radiosurgeon at Postgraduate Institute. I have been practicing gamma knife for nearly a decade. These are my disclosures. There is no financial disclosure for this talk. Sorry. These are my disclosures. The slide. Yeah. So just to take you to my place, it's in the foothills of Himalaya near capital New Delhi. It's a beautiful place. My hospital is a public sector hospital which takes care of nearly 80 million patient population. The history of gamma knife in India dates back to 1996, and my center was the latest, having perfection at that time, and we treat 500 plus patients per year, mostly benign vascular and the functional ailments. So paragangliomas, for the today's topic, also known as glomus tumor, are relatively rare tumor with an incidence of 1 case per 1.3 million patient population. The usual age of presentation is in the 5th or 6th decade of life, with a slightly higher incidence in the female population. The common modes of presentation are tinnitus, headache, lower cranial nerve deficit, features of the brainstem or the cerebellar compression. These are slow-growing benign tumors with an average growth rate of 0.8 millimeter per year and estimated tumor doubling time of 14 years. These tumors are notoriously hypervascular, and that is the same reason that even the hardcore traditional neurosurgeons seek help from the allied branches such as interventional radiologist and the radiation therapist. The usual location of the tumor is near the petrous part of temporal bone, and they take origin from paraganglioma of the chemoreceptor bodies at the carotid body, jugular bulb, and the vagal ganglia. In 2% cases, the tumors are bilateral, while in 7 to 10%, we can have both glomus jugulare and carotid body. Nearly 1/5 of these grow intracranially. Most of these are sporadic tumors. Sometimes we can see in patients with VHL and MIN syndrome. Rare malignant variants have been reported in 1 to 5% cases. They present at an early age and suggest a potential for malignant or aggressive behavior. The majority of glomus tumors are benign. That is, these are the non-secretory paragangliomas, while 1% are secretory paragangliomas and they are responsible for hypertension and other neuroendocrinological problems, usually found associated with a few chromocytomas. The glomus, which should now better be known as paragangliomas, are a tumor of disputed identity, but their location is varied from cranial to many positions in the head and neck, and predominantly in relation to the paraganglioma cells. So if you find a glomus tumor, a small size glomus tumor sitting ideally at some place in the remote area of the skull base, what should you do? Earlier, when there were studies on the observation versus surgery for these tumors, the literature review found that there was no significant difference in the outcome of these patient population managed either with observation or surgery, especially except for the surgery-induced morbidity and mortality. It has prompted many of us to recommend the observation for non-progressive patients until there is a clinical radiological evidence of brainstem compression, neurological deterioration, or a secretory paraganglioma. Other clinical factors to be considered in the decision-making were age, symptomatology, the progression rate, and the Kanofsky performance scale. So a wait and watch approach can be offered to an elderly patient with tumors of small size. This policy may be pursued in cases of slow growing tumors, but the rapidly growing tumors should be offered treatment. And as a rule of thumb, and taking into account the possible measurement errors on the radiology, paragangliomas are considered radiologically progressive when they show a volumetric increase of more than 20% over a year. So if my patient does not fall in the wait and watch group, what do we have to offer? The surgical excision with or without embolization, the so-called gold standard treatment for tumor eradication, but I sincerely doubt if it is still the gold standard treatment. The radiosurgery, which has proven its candidature as an optimal primary therapy, is now the main treatment option. The conventional fractionation is still an option for cases who are not a candidate either for surgery or SRS, but with the hypofractionated regimes, multi-session SRS, it has definitely pushed the limits of the radiosurgery. So the indications are now pretty limited for surgery. The glomus tumor treatment has gradually shifted to a multimodal approach now, and this is an algorithm which is suggested by British Skull-Base Society. And among all these indications, I think the only indications left now for surgery are secreting tumors, significant brainstem compression, malignant disease, failure of the radiotherapy to control the tumor growth, and when you have a doubt in the diagnosis. So this patient presented to me with this paraganglioma with the features of brainstem compression. It was 70 cc in volume, and we managed it with surgery, embolization, radiosurgery, all the approaches. Until the development of the microsurgical techniques and modern interventional neuroradiology, potentially life-threatening vascular complications were pretty common, and the rates of post-operative cranial nerve deficits were high. And due to incomplete resection, the vast majority of the paragangliomas recurred. With modern techniques, local control can be achieved in around 80 to 90% cases. With time, our intraoperative armamentarium has also become better, and this translated in an improvement in the better surgical resection. But still, the morbidity and the mortality for glomus tumor is pretty high for the current standards. So surgery may help in tumor control, but the recurrence rate is not negligible even with the total resection. Nearly 4.5% patients have a CSF leak, and cranial nerve paresis is pretty high. If we attempt more resection, the morbidity profile is worse. So the optimal treatment for jugular paraganglioma has been a controversial issue. But with surgery, we are certain that there is a high risk of the post-operative cranial nerve deficit because of the intimate association of these tumors with the lower cranial nerves. The results of surgery can best be illustrated by a systematic review of 184 patients with the jugular paraganglioma who were treated with a variety of surgical approach, and the surgical control was achieved in 85%, which was defined as an alive patient without evidence of disease during the entire follow-up. But if you look at the morbidity profile, there were 1183 preoperative cranial nerve deficits, which increased to 12,148. So the surgery caused 965 new onset cranial neuropathy. And interestingly, the hearing loss was not included in this analysis because of the lack of reporting in the Mohs series. The incidence of the dead years after surgery in the 4 series totaling 266 cases of jugular paraganglioma was 45%. And I would like to bring your attention that the vagus was functionally preserved in only 11 patients. So you can understand the morbidity profile was pretty high. The treatment outcome of jugular paraganglioma was with the surgery and the radiosurgery series was compared. The tumor failure rate, major complication rates, deaths because of the tumor, number of the cranial nerve palsies after treatment was significantly high in the surgical series than the radiotherapy series. The outcome is true for both jugular and the vagal paragangliomas. And looking at the p-value, we find that the radiotherapy series was at an edge to the surgical series. In this another meta-analysis, the tumor control rate and the treatment-related morbidity for patients of paraganglioma, Ivan et al. Found a strikingly better outcome with the primary stereotactic radiosurgery compared to any other treatment modality. We can see this is the pooled analysis of the tumor control rate. And even with the gross total resection, the recurrence was found in nearly around 0 to 11% patients by the end of 4 to 11 years. And the postoperative cranial neuropathy was found in nearly 40% with a mortality of 0 to 3.4%. Now, I would like to draw your attention to the table 3, which mentions the quality of life. And in each and every domain of lower cranial nerves, any primary radiosurgery provided better outcome. I would rather use it with an adjective than excellent outcome compared to any surgical series. After a proven efficacy of radiation therapy over surgery, this was the time of comparison of the external beam radiation therapy with the stereotactic radiosurgery. And thanks to the particular conformality and selectivity of current radiosurgical dose planning in paraganglioma, SRS has shown a much higher tumor control rate and improvement in the cranial nerve paresis. If you look, there is no osteonecrosis, brain necrosis, or death with the SRS. The total complication profile was much better with the SRS technique in comparison to the EBRT techniques. The many literature reviews and the meta-analysis recently published on the management of paragangliomas report a local control rate after SRS of 94 to 100%, and this is significantly higher than the value found for the other radiation techniques. According to the published meta-analysis, both gamma knife and LINAC-based radiosurgeries provide a higher rate of the clinical control in paragangliomas, and that midterm follow-up of the clinical status, they either remain unchanged or improved in around 94 to 97% of these patients. This is my own analysis, which included 639 patients, and they had a local control rate of 94.2% at a mean follow-up of 9.7 to 123 months. And with better long-term tumor control and better morbidity profile, SRS has practically replaced IMRT or EBRT in the management of glomus tumor. This landmark study headed by Sheehan et al. Reported an overall control rate of 93%, and they found no difference in the tumor control rate with upfront or salvage radiosurgery. They predicted that the absence of trigeminal nerve dysfunction, stable or improved cranial nerve function at the last follow-up was positive predictors for the long-term tumor control. So if you still want to operate on this patient, we should ask ourselves, would I be able to bring the patient out in the same or the better status out of the theater? Keeping aside the surgeon's ego, in majority of the cases, the answer is no. And this is because of the unforgiving nature of the lower cranial nerves to even a minor mechanical stretch. Let's be sure in our mind first and then explain to the patient. What is your goal of the treatment? Is it a tumor eradication or tumor stabilization? We are practically dealing with a benign disease. Does it really matter if it gets inert and lie deep in some remote area of the skull base after radiosurgery? In my clinical practice, I find that none of my patients have an issue with radiosurgery knowing this fact. I explain to them that it's not going to disappear with radiosurgery. It may shrink a little, but whenever you will get a scan, it would be there in an inert state. Once in a while, some of my colleagues say that surgery has an acceptable complication rate, but I am not sure if your definition of acceptable complication is in sync with the patient's definition of the same. So the paradigm shift has already happened for this disease. We as neurosurgeons started with the maximum possible blood, then followed the middle path regime of the subtotal resection, followed by the radiation therapy. And now we are confident that the SRS is sufficient and the most safe treatment modality for this disease. If we look at the statistics, since 1968 to 2019, nearly 5,000 patients received gamma knife radiosurgery. This is the Lexel statistics, which account for only 1% of all benign indications of gamma knife radiosurgery. This is partly because of its relative rarity of the tumor and initial skepticism with SRS. However, the number are steadily increasing, and more glomus are now being treated with various radiosurgery platforms including cyberknife and other linac-based techniques. So we are actually sure that SRS should be the primary treatment for a small paraganglioma, but the large volume multi-compartmental paragangliomas are still a challenge. And we try to evaluate the safety and efficacy of primary hypofractionated multi-session gamma knife radiosurgery in our patient setup with the frame-based techniques and its comparison with the external beam radiation therapy and volume fractionation. We published this experience with the hypofractionated radiosurgery for jugular paragangliomas. This was our protocol, which is fairly similar, and for our single fraction also. We only include patients treated with the primary hypofractionated radiosurgery in this series. The reasons to fractionate was to avoid a radiation exposure to the brainstem and to preserve cochlea from foregrade radiation exposure in patients with the preserved hearing. The patients were managed prospectively on clinico-radiological follow-up. All patients were treated with the gamma knife perfection. We usually prescribe 15 to 24 gray in a single session. I go with a little higher dose than usually being practiced. Whenever we try hypofractionation, the prescription dose was 24 to 27 gray in 2 to 3 fractions with an interfraction interval of 24 hours. And in a single fraction that ranges, for a single fraction, it ranges to 7 to 9 gray at 50% isodose. And for the clinical evaluation, we monitored 10 potential neurological deficits related to the disease. The frame was fixed. It was kept fixed in situ over the patient's head throughout the procedure of 2 to 3 days. We included patients over a decade, and only patients with a prolonged follow-up were included in the analysis. 45 patients received single session and 17 were treated with hypofractionated regime. As you can see here, the neurological deficits at the presentation were much more in the patients treated with the hypofractionated regimes. Excuse me. The reason for the same have been the large volume of the tumor extending into the intra and the extracranial compartment. Strikingly, the complaint of headache was much more common in the large volume tumors. Rest of the complaints were comparable between the two groups, which included tinnitus, hearing loss, lower cranial nerve related symptomatology. In all these patients treated and followed up for at least 2 years, the majority either improved or remained stable. Only 2 patients developed new onset complaint, which was in the form of a headache, and in 1 patient, shoulder drooping. The predominant presenting symptoms were mixed conductive and the sensorineural hearing loss in nearly around 60 to 80% of these patients, and the tinnitus, that was a pulsatile tinnitus, facial weakness, headache, vertigo, hemiatrophy of the tongue, shoulder weakness, etc. And our series had shown a striking improvement in the headache, with 100% of these cases showing improvement by the 6 months of follow-up. The headache in cases of paraganglioma might be a dural stretch or a vascular headache or both. The pathophysiology behind the same is not known. We hypothesize that radiosurgery dampens the vascular flow inside the tumor with gradual obliteration of the channels that relieve the vascular headache and probably the complaint of the pulsatile tinnitus too. Looking at the volumetric reduction, since the average volume was 29.9 cc in the multi-session series, it reduced to 21.9. It reduced more in the cases with the single session radiosurgery technique. So this was 1 patient with a 47.63 cc extending down into the lower cervical spine and treated with the 7 gray in the 3 fraction. And by the end of 3 years, the volume reduced to 19.77 cc. The blue line here shows the original tumor outline at the superimposition of these images. Similarly, another patient treated in 8 gray in 3 fractions at 2 years, it reduced from 20.13 to 19 cc, then 17 cc at 4 years. And by the end of 6 years, 14.37 cc. Another patient at the end of 3 years treated with 16 gray, tumor volume reduced from 34.67 to 16.36. This patient treated in a single session with the 20 gray radiation. Actually, we need to preserve the brainstem from the 12 gray, so we can't. We have to have a dose constraint, and it reduced in 1 year. This was a pretty early response for the glomus also, and it reduced from 19.11 to 10.91 cc. This patient had a remarkable improvement in the complaint of tinnitus and headache by the end of 6 months only, and a good volumetric reduction. 28 female, pulsatile tinnitus, vertigo. So that's the usual response with the radiosurgery that we see. Another patient treated with a hypofractionated regime, showing a good volumetric reduction by the end of 2 years of the radiosurgery. So one should follow an objective criteria, and we follow the radiosurgery response classification for this. And most of these patients in the multi-session have shown a tumor shrinkage of more than 10%. So there are some common questions when we practice radiosurgery. The recommended dose for a single session radiosurgical treatment of a paraganglioma ranges from 12 to 18 gray at 50% isodose. There have been reports of the higher doses between 19 to 30 gray, affording the good outcome without appreciable side effects. The dose should be decided as per the tumor volume, the neighboring structures, the secretory status of the tumor. In the previous publication, we have elaborated the dosimetry profile for the hypofractionated regime, for the single session and the multi-session regime. And till now, there is no relationship has been observed between the radiation dose and the long-term tumor control. That's why the range is so high, from 12 gray to 30 gray actually. One very important question is that, which is directly related to the quality of life of patient, is whether any improvement in the cranial neuropathy happens or not. Because these patients present with difficulty in swallowing, altered speech. So this literature review clearly indicates that there is a definite improvement in the cranial nerve dysfunction. The extent of improvement may vary. I never assure patient that you will get this much improvement. You will get an improvement, but the extent of improvement will be only over the time, and it may take 2 to 3 years for its full effect to appear. Sometimes the patient gets experience the improvement over the further years also. It is necessary to maintain the treatment doses within the safety margin to avoid the chances of radiation-induced complications, especially radiation-induced cranial neuropathy, vascular occlusion, radiation-induced necrosis and edema. Most of these lower cranial nerves are actually motor in nature, hence inherently radio-resistant. A definite tolerable limit for the lower cranial nerves has not been defined yet. Is there a reduction in tumor volume after radiosurgery? So in this graph, patients, this is my own series, the patients with the more than 36 months follow-up we found, and less than 36 months follow-up we found. So the patients who are followed for a longer duration, they keep experiencing better tumor reduction in the long term and with the time also. Is volumetric reduction necessary for the clinical improvement? Even a subtle volumetric reduction leads to a clinically disproportionately significant improvement in the symptomatology. That is similar to the mechanical decompression of the lower cranial nerves. Our pooled analysis showed a symptom control rate of 86.9%. And Sheehan et al., who had the highest number of cases in their series, reported improvement of cranial neuropathy in 11% patients. And in our experience, we found that nearly 52% patients reported improvement, 48% had a static neurological status. It is noteworthy that the lower cranial nerves are very sensitive to mechanical stretch, and earlier surgical series have reported poor long-term outcome with the surgical reports because the nerves, they do not forgive you for the mechanical stretch. The most commonly reported complication of a single session SRS is hearing loss, which may be preserved in some patients with the hypofractionated SRS. I have experienced a better hearing preservation in patients with the fractionation schemes with the multi-session SRS, compared as you can spare the cochlea. So a single session SRS may cause unacceptable radiation spillage onto the brainstem and the cochlea. A fractionated SRS is an established technique now in brainstem, brain metastasis, meningiomas, AVM. We extrapolated that concept and we found that the multi-session SRS causes good symptomatic improvement with good long-term tumor control. This was one protocol which we can use for frame-based fixations with ICON and the other radiosurgery platforms. The frame is not an issue, so you can do that. But irrespective of the dose schedule, the 12 gray volume should be kept less than 10 cc. So the hypofractionated regime has several unanswered questions which are still evolving. Given that because when we go with the fractionation scheme, we need to calculate the dose for a single fraction. And given that the alpha beta ratio for the tumor is higher than the normal critical structures, the effect of the radiation on tumors is relatively less affected by the fractionation than the normal brain tissues. We have calculated the fractionated dose for paragangliomas, keeping the alpha beta 3. The other things were because the LQ equation does not work in the hypofractionation beyond 7 gray. So we evolved with time. We published our earlier experience with the large volume arteriovenous malformations, which we treated in 1, 2, 3 fractions. And now we have the schemes for the 2 fraction and the single fraction with the comparative single fraction dose, which we published in World Neurosurgery. So if I compare the different treatment modalities with a single session, surgery, routine radiation therapy, multi-session, I find that the SRS has a higher efficacy than any other treatment modality in the literature, with a good long-term tumor control and maintaining the excellent quality of life of the patient, which is actually the goal in the current times. Many times my residents also ask, does any classification scheme correlate with the SRS treatment? So whether it's a Fish or a Jackson, none of them is actually a radiosurgical series. These are for the surgical prognosis. So it doesn't matter to me whether it's a C or D. That's not going to affect my outcome. So the hypofractionated regime for the large volume multi-compartmental ones is safe, effective, potentially better treatment modalities for paragangliomas, unsuitable for the single session SRS, and better than the routine radiation therapies. The clinical and the radiological response for both multi-session and single session has been comparable. For large volume lesions which are extending up to the C3, means the third cervical vertebra, we can increase the reach by frame fixation on the maxilla. Traditionally, the lower limit of the gamma knife radiosurgery is up to the lower margin of the foramen magnum. To push the limits of the Lexel stereotactic frame for lesions extending up to the third cervical vertebra, we tried fixing the frame on the maxilla while minimizing the movement of the neck, and this increased the reach of radiosurgery to the third cervical vertebra. So she is one of our patients who received from fixation on the maxilla. To minimize the movements in the neck, we fixed a hard cervical collar and treated the patient at 90-degree gamma angle. The interested readers may go through the methodology in the published series. This technique proved quite helpful for reaching out to the lower margin of paragangliomas, which usually extend in the upper cervical spine. So this is one paraganglioma extending up to the C2 C3 junction. For now, with the frameless techniques, with the cyber knife or the ZAP, you can reach up to for the lesions in the upper cervical spine without much difficulty. This was a very innovative technique and which got good reviews from the Marcia group. And when the lesion is extending in the neck, there are chances of the target movement with the physiological movements such as sneezing, deglutition, etc. My dear friend Constantin published a wonderful article to minimize this movement with the fixation of the teeth and the jaw fixation. So gamma knife, every treatment modality has its own set of complications, similar with the SRS also. Sheehan et al. Reported a neurological deterioration in 6% of patients, especially related to the transient cranial neuropathies, impaired hearing, intractable vertigo. Such complications may appear in subacute to chronic fashion. Lower cranial nerves are usually considered to tolerate radiation exposure up to 25 gray in a single session. Nearly 50% of patients report a resolution of tinnitus. If the patient has a clinical deterioration, then 1/4 of these patients present with the signs of neurological tumor progression. Cheng Chiali identified trigeminal nerve dysfunction at the time of stereotactic radiosurgery as a predictor of future tumor progression. The trigeminal nerve dysfunction indicates an extensive high volume tumor which may need subtotal resection followed by stereotactic radiosurgery. In our pooled analysis, the complication rate was for the conventional radiation was 7.9%, and in comparison to this, SRS is pretty safe. An interesting complication which I noted for the seemingly superficial lesion is a temporary non-cicatricial focal alopecia following gamma knife radiosurgery. So 2 of my patients of paraganglioma, they developed an alopecia within a month of the radiation. Thankfully, it's a transient phenomena, and we should avoid exposing the dermal appendages to more than 3 gray radiation. All these patients get the same quality of the hair growth by the end of 2 to 3 months. Some patients may develop a radiation-induced edema or necrosis sometimes, and these patients, if they are resistant, you may need to give bevacizumab or Trental and the vitamin E combination. One essential prerequisite before deciding on primary radiosurgery is to ascertain the perceived pathology in radiology. I have burnt my hands. So radiosurgery should never be offered when the diagnosis is questionable. If needed, paraganglioma should be prior evaluated on MRI, CT, or DSA to differentiate it from other possible skull-based pathologies, which may be schwannomas, meningiomas, endolymphatic sac tumor, sometimes metastasis. So this patient actually received treatment at another center, did not respond even after a decade, and then presented with a florid posterior fossa edema. Unfortunately, she died, and on the autopsy, we found that it was always an primary intracranial extraskeletal mesenchymal chondrosarcoma. It was a clinical mimicry as a glomus tumor. We lost the patient. So I can say safely now that SRS is safe and effective treatment modality for a paraganglioma with an excellent long-term clinical and radiological outcome. and it should be offered as a primary treatment option for paragangliomas rather than as a salvage therapy. While choosing a modality, certain hidden aspects need to be considered too, like the need for the hospital admission, recurring cost of visiting the hospital, absence from the workplace, and need for the adjuvant treatment. In all these parameters, the stereotactic radiosurgery does much better in comparison to surgery and conventional radiation technique also. The anecdotal case reports on the effect of external radiotherapy on the functional paragangliomas has reported dismal outcome. The reasons might be twofold. The prescribed radiation dose was less, and the chief cells which are responsible for the catecholamine secretion were not affected at the conventional dosing. So this case report by Veronica, they have reported a secretory paraganglioma. They observed a transient rise in the catecholamine 3 to 5 months post SRS. This transient phenomena is probably because of the tumor cell destruction after SRS. The levels reached to nearly half of the pre-SRS level by the end of second year and then reached baseline by the end of 32 months. I compared the situation as of a functional pituitary adenoma where you give radiation in the dose of 23 to 25 gray. Here also, authors recommended a higher than the usual dose, and to avoid any hypertensive crisis, the patient should have appropriate alpha beta blockage before and after SRS for a prolonged duration, which may range from 3 to 4 years as well. Principally, I agree that for a secretory paraganglioma, surgery should remain the first treatment option. Proton radiosurgery is another option which is coming fast, and I could not find much literature over it, but this recently published report showed promising result. So the issues right now is that the literature is not that much, had not been that much robust. There were issues of the immobilization for the lesions extending down, and issues with the radiological diagnosis. The dose was not confirmed, and we should be open to take a multimodal approach when there are brainstem compression or other clinical features and the secretory paragangliomas. Like, I wouldn't like to be like this dog in treating this glomus tumor with a radiosurgery alone. Thank you so much.
Thank you, Manjul. That was quite a tour through the landscape of paragangliomas, and it raised some questions for me, and I have at least a few questions from the audience. And I'm going to start with the first of these, and we'll take one at a time, and I'll interject my own, and I have a very important philosophical one at the end. So first, somebody asked, this said the skull definitions shown in the red contour were way off your slide slide number 40 to 41. So something to do with the skull definitions on your slide 40 to 41. Could you comment on the reason for that? Was this some dosimetric reason?
Actually, these were the superimposed images. These, the first image is usually the one which is extremely on the left side in the slide number 40, which is having the fiducial. The rest ones were actually the superimposed images. That's why you are not able to see the contour over there. So they are actually the ones which we had the comparison at the follow-up, not at the time of the treatment. That's why there is a little discrepancy over there.
Okay, so image fusion issues. Okay. So you did show an example of where there was a failure to diagnose there was a chondrosarcoma. And so this aspect, it was included in your talk, but maybe you could flesh it out a little bit more. So how did you differentiate from other skull-based tumors on an ongoing basis prior to radiosurgery? Did you do angiograms in people? Were some biopsied? Clearly, there's some circumstances where the diagnosis is ambiguous. And someone asked, would you suggest endocrine evaluation prior to treatment if picking up perhaps a catecholamine secreting lesion?
That's a very, very valid and excellent question, which I always expect somebody to ask, because there are so many mimickers, so many radiological masqueraders over there as chordoma, chondrosarcomas, lower cranial schwannomas, meningiomas, endolymphatic sac tumors, metastasis. So you have to take a very good clinical history, and you should be open for discussion with your radiologist. Many a times, I am not sure if I have 2 or 3 differential in my head, and then I call my radiology colleague, I get a CT scan, look at the skull-based destruction pattern, and I get an angiography, because we get an excellent blush on a glomus, which is usually not seen with any of these other tumors. So with some basic techniques of just a temporal bone 3D CT, looking at the bony destruction pattern and angiography, in 99% cases, we can be sure. If we are not sure, I take the help of the PET scan also if the tumor is a little large, and the PET helps in differentiating these tumors. So it usually doesn't need a biopsy in any case. If I'm not sure, even after this much exercise, I definitely go with my surgical team to get a biopsy and then go with it. But it hardly happens. It has not happened in more than 2 or 3 cases so far.
Gotcha. So, I mean, you moved pretty quickly, but was it clear that you've treated more than 600 glomus jugular tumors in your center? Was that the?
No. That was actually the literature review on the gamma knife.
Okay.
That is not my series.
So,
that was a literature review. I have treated nearly around 160 patients.
160. Well, that's a big number. I mean, it's twice what we've done at Stanford or so. So can you, I wasn't clear to me, you moved quickly, as to what is the dividing line between single session and multi-session radiosurgery for you?
Yeah. So, John, I prefer a higher dose than what is given in the literature, because the literature shows that the dose might be from 12 to 18 gray. So I preferred giving nearly around 20 gray to most of these patients. The reasons was, I think that it's a pretty vascular tumor. I consider it something like on the line of AVM. The vascularity channels of a glomus tumor are that much hypervascular, that's like of an AVM. And for AVM, we give dose of nearly 20 to 25 gray, more than 22 gray usually. So that's why when this is near to the brainstem, I have to preserve the brainstem from a 12 gray radiation exposure. If I'm not able to preserve the brainstem despite my best of the planning, I fractionate it into 2 or 3. And as I showed the fractionation scheme, so in those cases, I try to give a dose higher, nearly 20 to 22 gray, and I fractionate it into 2 to 3 so that brainstem should be away from the 12 gray radiation exposure. And rarely a patient, if patient has a functional hearing and the cochlea is getting more than 4 gray radiation exposure in a single session, I try to fractionate to preserve the hearing.
Great. Well, I've arrived at the same rationale, and I too think that the cellular target is endothelium in these, much like it is with an AVM, and I could totally understand and agree with your rationale for treating to 20 gray. So, so you don't necessarily know a priori before you put a frame on the patient and plan them whether they're going to be a single session or multi-session, or do you?
Usually I am sure that this is going to be, one is I can get an idea of the tumor volume. If it is somewhere around 20 or 25 cc or more than 20 cc, it usually needs a fractionation at my center.
That's the number I'm looking for. So about 20 cc, then you kind of flip into what's likely to be a multi-session approach. Now, question, have you done any stage treatments rather than multi-session?
Not for glomus, and the reason for that is actually a logistic at my center, because most of my patients are actually not able to afford the multi-session treatment, so I have to treat them in a single session. So in a single session, even if I treat them in a single hospital admission, if I treat them up to 5 fractions, they have to pay only once. But if I have to admit them after 6 months for the second session of the volume fractionation, that wouldn't be possible for most of my patients. So that's a logistic issue at my center. That's why we are the hypofractionated, dose fractionated regimes.
How about doing a stage procedure that involves different portions of the tumor over successive days rather than the entire tumor volume all in one session? Does that make sense? Rather than fractionating the entire lesion or treating in multi-sessions the entire lesion, treating separate portions of the tumor in successive days. Would that ever make sense?
That's an excellent question. The reason is that the intracranial compartment is usually in close vicinity to the brainstem. So if I try to treat that portion with the 20 gray, which is stuck to the brainstem, or it doesn't have a safe distance, if that portion separately to be treated with a large dose, that wouldn't be possible in a single session also.
Makes sense. So before I launch into my final question, or my own question, I want one other. So would you comment on the alpha beta ratios that you like to apply to these tumors and regions?
considering, we calculated the doses on the BED, considering an alpha beta of 3 for this, because it's a sort of benign disorder, not that much rapidly progressing. So we considered it to take it in the 3, and the BED is calculated in that way.
Makes sense. So here's my final question, and it's kind of philosophical. Why would anyone continue to do an open surgery on glomus tumors in this day and age? I'm going to argue that the data has been pretty good now for more than a decade, that radiosurgery is superior to surgery. Why would anyone do open surgery?
Just to satisfy a surgeon's ego, or the indications are secretory and the brainstem compression. There is no other indication. All these, even the large volume ones, can be very safely, effectively treated with a radiosurgery. So I do not find any reason except for 2 and 3 specific ones, as I earlier told: secretory paragangliomas, significant brainstem compression, and you have a doubt in the pathology. That's the only reason which are in my mind. I'm pretty clear and confident about it, that these are the sole indications for surgery now. For rest of the things, SRS is sufficient enough to take care of the things, and that is going to give a very good long-term tumor control and an excellent quality of life, which actually matters to the patient.
Well, I of course agree, but and just for the record, kind of one of the whole reasons I started ZAP was because of this problem around glomus jugulary tumors. I decided a long time ago that patients are not getting the correct treatment because the surgeons of interest don't have the correct tools in their hands. And yes, you have a gamma knife, but too many surgeons don't have access to the right tools. And it's both a financial issue, I think it's an ego and a power issue. And hopefully we believe that by putting the proper tools directly in the hands of more neurosurgeons, that we'll see the right treatment, patients get ultimately the right treatment. So, I think, Dr. Tripathi, this was a dramatic and impressive walk through a very complex subject. You've mastered this disease with radiosurgery, and I salute you. And I hope that soon, not just many patients, but really all patients with glomus jugulary tumors are getting the sort of treatment that you espoused here. So thank you, and thank our audience for joining us wherever you are in the world. It was a great and a fun ride here. Thank you, Dr.
John.
Tripathi.
Thank you so
Everyone,
much.
stay safe. Bye-bye now.
Good day.